This video is about a conversation that almost didn't happen. A conversation between a young woman who medically transitioned as a child and later detransitioned, and psychologist Jordan B. Peterson. What makes this conversation different is not outrage, not politics, not slogans, but something much rarer. An attempt to understand what actually happened psychologically, developmentally, and emotionally. This is not a debate. It's a reconstruction of a life story, and the ideas used to explain it. Here's what was said. The woman begins by describing her experience. At age 12, she started experiencing gender dysphoria. She was taken to therapy. She received a diagnosis. By 13, she was placed on puberty blockers. Soon after, she was put on cross-sex hormones. At 15, she underwent a double mastectomy. By 16, she stopped transitioning. She says clearly, "It turned out not to be the best decision for me." Peterson asks her to go back further, before the diagnosis, before the medical steps. When did puberty start? She explains that her puberty began unusually early, around age 9. And emotionally, she says, it was extremely difficult. Peterson pauses the personal story and introduces background psychology. Before puberty, boys and girls experience roughly equal levels of negative emotion. Things like anxiety, emotional pain, frustration, shame, guilt, and self-consciousness. But at puberty, something changes, especially for girls. Across cultures, women show higher sensitivity to negative emotion than men, and this difference emerges at puberty. No one knows exactly why, but there are plausible explanations. First, physical vulnerability. After puberty, males become taller, stronger, and more physically dominant. From an evolutionary perspective, heightened threat sensitivity in females makes sense. Second, sexual vulnerability. Women bear far higher reproductive costs: pregnancy, childbirth, long-term infant dependency. That also selects for greater sensitivity to sexual threat. Third, caregiving. Women historically carry primary responsibility for infants, extremely fragile and deep. Now add early puberty. If puberty starts earlier than peers, the emotional burden hits before neurological maturity is in place. That makes everything harder. Peterson explains that adolescent girls' negative emotion often becomes focused on the body, especially body shame and self-consciousness. Why? Because women are evaluated more harshly on physical appearance, by men and by other women. Men may be judged more on status or performance, but women are judged intensely on attractiveness. That creates a psychologically volatile situation for girls entering puberty. The woman responds, "None of this was ever explained to her, not by therapists, not growing up." And she says something striking. Almost everything Peterson described played a role in her distress, her transition, and eventually her detransition. She adds another layer. Growing up, she was a tomboy. She later learned she is on the autism spectrum, diagnosed only last year. That mattered. She struggled to socialize with girls. She fit in more easily with boys. Early in puberty, she was tall and physically capable. She could keep up with them. But as time passed, the boys grew taller and stronger, and that gap widened. At the same time, social interactions became more sexualized. She no longer fit with girls, but she was also losing her place among boys. She describes profound loneliness. Peterson explains something crucial here. The most reliable psychological difference between males and females is not intelligence or ability. It's interest orientation. Males tend to be more interested in things. Females tend to be more interested in people. People on the autism spectrum also tend to be strongly thing-oriented. So someone who is both female and autistic may feel out of sync with. Peterson connects this to self-consciousness. Self-consciousness is tightly linked to negative emotion, almost statistically indistinguishable from anxiety. Girls, whose social value is often tied to appearance, tend to turn that self-consciousness inward, toward their bodies. The woman describes growing up in an image-focused, sexualized culture. Before puberty, she expected her body to develop in a certain way. It didn't. She was thin, small-chested, slightly muscular, broad-shouldered. The cultural ideal around her was curvy, voluptuous, hourglass-shaped. She felt she didn't look like a girl at all. She cut her hair short. She believed she wasn't pretty and never would be. Peterson responds bluntly. It is extremely rare, especially for girls, to feel attractive in the early stages of puberty. What she experienced, though painful, was tragically common. Then Peterson reframes gender dysphoria itself. He asks the audience to imagine it as having two components. First, a general tendency toward negative emotion, anxiety, depression, shame, guilt, pain, self-consciousness. Second, a specific focus of that distress on the body. The first component is the majority of the problem. Across mental illness, the strongest predictor of suffering is high negative emotion, not the specific form it takes. Gender dysphoria, in this framing, is one manifestation, not the root cause. This leads to a controversial point. Claims that gender dysphoria itself uniquely increases suicide risk are misleading. The elevated risk comes from depression and anxiety, which often coexist with dysphoria, not necessarily from dysphoria itself. This distinction matters, because treating the manifestation is not the same as treating the cause. Peterson then references long-term studies. Before this issue became politicized, researcher Ken Zucker ran a gender dysphoria clinic in Toronto. Zucker was not ideological, just empirical. What his peer-reviewed research consistently showed was this. If children with gender dysphoria were left alone until adulthood, 80 to 90% eventually reconciled with their biological sex. Around 80% later identified as homosexual. In other words, gender dysphoria often resolved naturally with time. The typical pathway looked like this. A temperamentally gender non-conforming child, prone to anxiety and depression, experiences intense dysphoria at puberty. But if medical intervention is withheld, most stabilize. Peterson's implication is quiet, but devastating. Time itself was a treatment. This conversation doesn't offer slogans. It doesn't deny suffering. It doesn't mock it. It doesn't simplify it. Instead, it asks a harder question. What happens when we mistake developmental distress for a fixed identity? And what do we lose when we intervene too early to find out? This was not a political argument. It was an attempt to understand a life before it was permanently altered.